COPD, chronic obstructive pulmonary disease, is more of an umbrella disorder. It includes emphysema, asthma, bronchitis. With emphysema, a characteristic trait would be the barreled chest. Asthma is wheezing. Bronchitis comes on and off. As all chronic conditions, you have exacerbations. But more so with bronchitis, you have an inflammation of the trachea and bronchi. As it relates to asthmatics, we want to be mindful of their administration of their inhalers and be sure of which one to use first. So if they have a glucose inhaler and a bronchodilator, we want to make sure we dilate the bronchioles before we use a maintenance dose inhaler. So rescue, then maintain. Tuberculosis. Tuberculosis has a series of medication that needs to be taken. The main problem with tuberculosis is that people are non-compliant. So these are some medications that are commonly given with tuberculosis. And we just want to be aware of what side effects that they have so we can teach the patient so that they will stay on the medication if they exhibit these signs or report to the provider if they're having this problem. Okay. With rifampin, we want to remind them of the red-orange fluid effect that it has. With INH, it causes peripheral neuritis. Pyrazanamide causes an increase in uric acid. Ethambutol causes eye problems. And streptomycin causes nephro or ototoxicity. TB has several different ways of getting to the confirmed diagnosis. So first they will be administered what's called a PPD or a positive protein derivative. That's a TB skin test. If that shows as being positive, they will do a chest x-ray, and further investigation will be a sputum culture, which is best and taken in the morning. Wound stages. Stage 1, stage 2, stage 3, and stage 4. Stage 1 is a non-blanchable area. Stage 2, you have absence of the epidermis. Stage 3, dermal layer is absent. Now we're down to the sub-Q layer in stage 3. Stage 4, the sub-Q layer is absent. And now we are exposing muscle and bone. Diabetes. Diabetes can be type 1 or type 2. Type 1 diabetes is known as insulin-dependent diabetes, IDDM. Type 2 diabetics is known as non-insulin dependent diabetes. Type 1 used to be referred to as juvenile diabetes. So with type 1, our main concern is to avoid DKA. DKA is diabetic ketoacidosis. Common symptoms of DKA: Kussmaul's respiration, acetone breath or fruity breath, and ketonuria. We are trying to avoid DKA with type 1 diabetes. Type 2 diabetics, we are trying to avoid HHNK, hyperglycemic hyperosmolar non-chaotic syndrome, which is indicated by an elevated blood sugar, very, very high blood sugar. That is what we want to avoid. Okay. Cushing syndrome. A patient that has Cushing syndrome are going to exhibit signs of prednisone toxicity. They are both the same in nature. So with Cushing syndrome, you have an oversecretion of hormones. So you're going to have truncal obesity. You're going to have purple striae. If you're a man, you could be a victim of gynecomastia. As a woman, hirsutism, amenorrhea. And you'll have atrophy of your extremities, low muscle tone, muscular atrophy. With Cushing's, we want to monitor the vital signs. We may have to prepare the patient for adrenalectomy if the condition results from an adrenal adenoma. Following an adrenal adenectomy, they would need replacement therapy. Addison's disease. Addison's disease, they are in need of more hormones. So you need to add more hormones. These people have a bronze color about themselves. They're going to be fragile. They're going to have a decreased resistance to stress. They're going to have a low sodium, low blood sugar, low blood pressure, high potassium. And we need to apply replacement therapy for these people. Corticosteroid replacement therapy. Variant medications, levothyroxine. Drug of choice for hypothyroidism. The thing about levothyroxine that we need to teach is that they have to take it forever. This will make them non-compliant. But we need to educate them on the importance of taking this medication for life to avoid other problems associated with hypothyroidism. So hypothyroidism is a decrease in secretion of thyroid hormones. So their level of metabolism isn't on the right pace. We also want to encourage them to take levothyroxine in the morning for best results, considering that this medication does cause insomnia. So it's better to take it in the morning. PTU, or propylthiouracil, is a medication given for hyperthyroidism. And with this medication, we want to be mindful that we monitor the white count. Because this medication is also a chemo drug. So it can cause leukopenia. Okay. Warfarin. Warfarin is an anticoagulant. This medication has a lab value to be measured, which is PTINR. And the antidote to warfarin is vitamin K. This medication can be taken for life. And the lab has to be routinely monitored. Heparin, given sub-Q or IV, can only be taken for 21 days. And this helps to thin the blood. Is typically a prophylactic for DVT post-surgery. This medication does have a lab as well, APTT. Cardiac dysrhythmias. Okay. Cardiac dysrhythmias. You have several different types of dysrhythmias. Sinus bradycardia, sinus tachycardia, AFib, PVC or premature ventricular contractions, VTAC or VFib, most common. So starting off, we have what's called normal sinus rhythm, and that's when that rhythm originates from the SA node. Sinus bradycardia, you'll have an atrial and ventricular rhythm that are regular. And we can note that we know the heart rate when you're counting the R's on the QRS complex. That will tell you the heart rate. There is a formula for that. One thing about atrial fibrillation, the drug of choice is warfarin for that. Atrial fibrillation, you have multiple rapid impulses from many foci, and they depolarize in the atria. And that will cause a formation of thrombus because of that atrial quiver. It's not complete. So that causes to throw clots. VTAC, ventricular tachycardia, that's repetition of firing. That's a very mad ventricle. That is VTAC. It can be life-threatening. VFib, another life-threatening. That's a chaotic ventricle quiver. Chaotic ventricle quiver is VFib. VFib is fatal. VFib is a fatal dysrhythmia. Peritoneal dialysis. Peritoneal dialysis is achieved and the membrane is assessed by inserting a PD catheter through the abdomen. So this is abdominal dialysis. And this is done by diffusion, osmosis. And what happens is that the transfer of the fluid from the bloodstream through the peritoneum into the dialysate solution. What we try to prevent with this? Peritonitis. We can note that the influx must be the same as the outflow. What goes in must come out. If we notice that the outflow is inadequate, we may want to try to reposition the patient. As a side note, you want to remember, anytime it comes between patient or machine, you want to choose the patient first. And that's for any type of situation. If you have a ventilator that's going off, if you have a IV that's going off, or anything like that that's going off, you want to check the patient first before you assess the machine. Okay. Lastly, pain management. In managing pain in a client, you want to first determine, is this acute or is it chronic? We manage those differently. Acute pain is managed through cold therapy. Chronic pain is managed through heat therapy. So those are the difference. We also want to keep in mind of opiate abuse. So when to use your opiates. And in between opiate use, we want to encourage breakthrough pain management. And those are your NSAIDs, Tylenols, things like that that we use in between opiates to keep pain management on a roll. Also within pain management, if you have somebody that has a terminal illness, then when we manage pain, it's always going to be ATC pain meds, or around the clock pain management. Mental health. Mental health. With mental health, we want to ensure that we maintain a trusting relationship. That is the key to mental health, maintaining a trusting relationship. You also want to set boundaries. In nutrition and safety is key. You want to allow people that have that dominating personality as it relates to mental health. You want to give them something to do. If they attempt to monopolize group therapy, then give them a leadership role. Assign them a position. This is heavy therapeutic communication. You always want to acknowledge the person's feelings. as it relates to mental health. We don't want to antagonize. We don't want to use why questions or anything like that. Common therapies that you want to be alert about would be medications for bipolar, lithium is a bipolar drug, SSRIs, selective serotonin reuptake inhibitors, used for depression, anti-anxiety medications, or what we call benzo. These are your PAM and LAM family. Okay, alprazolam, diazepam, Xanax, Valium, things like that. You want to watch for safety when using these medications. Okay, this will conclude our lecture portion.